Welcome back, everyone, to the RangeMaster video cast. This week we have a special guest. Julia Walton is a physical therapist, physiotherapist in Manchester, England. And she's published a book on shoulder rehabilitation, which, of course, here at RangeMaster, we're obviously interested. Many of you know us already as the producer of literally 200,000 shoulder pulleys a year going out to patients around the country. But we know that shoulder pulleys don't come along until generally after someone has talked to a therapist and even understood what that term meant. But today I'm anxious to just visit with Julia about where she went to school, how she got this interest in shoulders, who she's collaborating with, and kind of things she might have to tell us about her experience. So Julia, why don't you introduce yourself and introduce your book, and then also introduce your website. So I'll prompt you along the way if you miss any of those.
Thank you. Lovely. So I'm Julia Walton. I'm a specialist shoulder physiotherapy and extended scope practitioner. So in the UK, extended scope practitioner works alongside the orthopedic surgical team and sees patients in my role on behalf of the consultants for their post-op follow-up checks. And we work in clinic alongside each other, me providing rehabilitation advice and guiding the patient on their journey. So I graduated, it feels like a long time ago now, in 1999 from Nottingham University. And I spent my training for the next 3 or 4 years actually in Nottingham itself, in the teaching hospitals there. And then it was there that I discovered my passion for shoulder rehabilitation. I worked with Professor Angus Wallace and Mr. Neumann, very eminent shoulder surgeons. And yes, developed my passion really for the shoulder. It was one of the first units in the UK to have a multidisciplinary team to manage complex shoulder problems, from instability to arthritis to tendinopathy. And we work closely with occupational therapists as well. And then circumstances and husband and moving took me to Bristol, so another city, another teaching hospital in the southwest of England. And it's there that I helped set up and establish a shoulder unit there with some shoulder colleagues, surgeon colleagues and therapists, to eventually end up at Wrightington, which was the dream ticket for me. It's a world-renowned orthopedic hospital which developed the first ever hip replacement with John Charnley. So it is the birthplace of the arthroplasty. And it's a wonderful place to work. So I'm part of that multidisciplinary team now, which is a tight-knit group of surgeons and physio and occupational therapists. And it has many fellows that come through from all over the world to spend time working with our team. This is where we've developed the book.
Let me back up for all of our physical therapists who listen to us. Tell us how you got started in physical therapy. Here we see a lot of athletes choose the physical therapy pathway. What was how did your decision come about to become a physiotherapist?
I think from a very young age, I wanted to be in healthcare, but I didn't want to be a doctor. I didn't want to be a nurse. I loved sport, I loved dancing, but I was never good enough to make it. My one way really to get close to that world was as a physiotherapist. So it really ticked lots of boxes. Yes, I thought it would open lots of doors. I originally thought I'd probably go into physical therapy for dancing. And it was during my training that I actually Really found pediatrics, and I really loved pediatrics, which is an element that I work in now, mainly with adolescents, but I really do enjoy that work.
Okay.
Yeah.
That makes sense. And you started to speak about your book. Again, could you give us the title of your book and where people can go to see it? Because I think you've published it free access online.
That's right. So the book is called Shoulder Rehabilitation, and it's a comprehensive guide to shoulder exercise therapy. So we have the link on shoulderdoc.co.uk, which is my colleague Leonard Funk, Professor Leonard Funk's website, which is a great resource for clinicians, but also for patients. And the link is on there. It was also released on Twitter, which is where it's, I think, being passed around, probably have a biggest exposure to. So they're the places that I think are the most easiest places to find it on. So on my at Julia, Physio Julia, sorry, I think the link is there, but also through Shoulder Doc.
We'll try to get all those little links and put them
Thank you.
up
Yes.
when we do that. And you had some collaborators with you. Tell us
That's
who
right.
you're working with there.
So the initial concept of the book came about in about 2007, and I wasn't actually involved at that point, but my two colleagues worked with Leonard Funk, so Kathleen Tatlow and Kath Leffley. Kath Leffley being also an author now. And it really came about when the evidence that was around to guide physiotherapists was really starting to develop, and the challenges to the conventional time frame rehabilitation process was starting to be challenged to really make sure that rehabilitation was effective and safe. And it was a big leap, really, in the early 2000s to start doing things that weren't necessarily pendular exercises and staying in a sling for 6 weeks, but the science was starting to come through. So it was a really nice concept, which began in those early stages, to help guide Professor Funk's patients on this journey and get the best out of the surgery in the most safe and effective way. So this concept developed over the years, and so in about 2012, 2013, we revisited the whole concept with lots of really exciting physical therapy, physiotherapy, science, EMG studies, looking at exercises, and again, what was going to be safe and effective, but also it became apparent through a lot of our teaching and our own continuing professional development that there was a big void in knowing and actually understanding a repertoire of exercises available to us as physical therapists, and at what point we use these. So it was very easy for myself and my co-authors to be using these as our general practice was shoulders. But for clinicians that maybe weren't seeing shoulders as frequently, you have your safe go-to exercises, but actually there was a lot more out there. And this was really aiding that and increasing that repertoire with safety, really, and that confidence.
Let's talk about that for a minute, because you're in a unique environment there at the hospital. I don't sense that there's a good deal of data gathering going on at the normal down the street around the corner clinic. And there is probably a lot of anecdotal evidence being applied that dates back to when a particular person was in school. And I'm not sure that here in the US, it's been uniformly adopted that you can begin earlier, that pendulum shouldn't be the first thing, that it's good necessarily to get out of that sling sooner than 6 weeks. Give us an idea about your take on the uptake of new research and its incorporation into everyday practice.
I think the first thing is having that trust with your surgeons, and I think it's you know, I'm in a very privileged position where I work very closely with them, and you know, the trust comes from having that dialogue, and also seeing the fruits of the labour, really. But in regards to giving clinicians, whether they're your colleagues in surgery, the confidence in new approaches, it is a challenge. If you look at the research out there, looking at accelerated versus slower rehab, there's often very little clinical difference between some of these two approaches. So therefore, you can either take one or the other stance, really. You can say, well, there's no difference, so we'll stay as we are because we're safe and I feel more confident in that cuff repair. Or you can say, there is no difference, that we have faith in the physical therapist. So, but, you know, as with everybody, it comes down to trust. And, you know, it's if you've got resources like this book, and all the plethora of really good stuff that's being done by colleagues around the world, I think it's really an exciting time for challenging, but I think in a kind way. I think we need to remember that, you know, a surgeon does an operation and that surgery needs to work. So it's not well, the evidence says this and it's boom bust and we've just got to get cracking and move. You can't force these concepts on people. You've got to collaborate.
Well, they're in the hospital where you're working side by side in a multidisciplinary team. What is it like in England in general? I know here in the States, it feels like the surgeon is fairly quick to pass off the patient to the physiotherapy team and rely on them and move on to the next patient. But it sounds like in your environment there, there's a longer lasting stickiness between the doctor, the therapist, and the patient. Is that correct?
Yes, yeah, I mean, it probably varies because we're a tertiary referral centre as well as managing our own local patients, because we're a national health hospital, so
Right.
public health as well as private. You know, what you tend to find, I think, you know, it would be wrong to think these patients never go away because they'll always be your problem. So if they're like a bad penny, they'll always come back if something's not right. So, or it's your reputation, isn't it? They'll go around other people saying that something's not right. So I think it's a false economy. So we tend to see in our unit and in the units that I've worked on, the patient really stays with the surgeon until, you know, everything has been exhausted or a second opinion has been sought. So for example, at Wrightington, we will see our patients in clinic as a surgical team and in my extended scope role at 3 weeks post-surgery, 3 months post-surgery. And at that point, if everything's going well, they will be discharged, but in a way that they've already started that relationship. So if there's any problems, they can be re-referred by the general practitioner. If it's an arthroplasty patient, they're ours for life, so we don't discharge them. So they stay with us. So we'll keep them on a surveillance program for every year. So a year, 2 years, 5 years, 7 years, 10 years, just to monitor any radiographic changes, any issues, changes in symptoms. And yes, they're with us for the long haul.
What about the initial engagement? Do you initially engage with them prior to surgery to get them familiar? What's your protocol there or standard?
So a lot of the time we're picking them up in clinic from primary care, so from the general practitioner with shoulder problems, they come into the clinic, and before they engage, so for example, a cuff tear, if it's appropriate, it'll be listed for surgery, but before that point, we'll make sure as a team that they've exhausted all conservative management. I mean, there's the traumatic tears, and that's a whole, you know, another debate. But in regards to surgery, the patient's got to be in the right place. It's the right operation for the right person and the right time. And a lot of those patients have to go through that rehabilitation program And a really nice buy-in, which we use, is literally if a patient is dead set on surgery, we have a little bit of a waiting list in the NHS, which is with COVID, sadly, has exponentially grown. But even for the private patient that could be done the following week, actually selling them, let's get you prehabbed, let's get you in the best state possible, so that when you have the surgery, you have the limited amount of downtime before you then bounce back on the other side. So a really nice selling point, I tend to say, is let's just preload it. Let's get you in a really good place. If by doing all of that, we have avoided surgery, you're the winner.
Yeah.
If by getting you to a really good place, you're a winner, because on the other side of surgery, you're well versed, you know what's happening, you're familiar with me, you're familiar with therapy, and literally we have the minimal downtime in that sling and we are up and off again. So it's a nice way of selling.
During the pandemic, did you make use of any telehealth, either pre-op or post-op?
A lot. and we're still doing it. Yes, no, we are, our directive from the National Health Service in the UK is to make 30% of all contacts virtual. So in physiotherapy, we are with our caseload, they are a little bit more complex. So if they're safe to do so and they weren't shielding for medical reasons, they would be seen face to face to get the best out of the interaction. But anything that's just a checkup or problem solving will be done virtually over this sort of medium, really, video and telephone, just as touch base. It was incredibly useful in the first wave when everyone was very anxious and the hospitals just stopped. It was like a tumbleweed. And then slowly we found a nice hybrid. So a lot of our patients travel, several, 2 to 3 hours for their appointments. And there's a really interesting psychology that's become quite apparent in the fact that attending a hospital appointment is a bit like setting you back psychologically. It's like knocking off a psychological scab. And the fact that, the whole palaver of coming into the hospital setting, gets that psychology going. They're preparing for the week before, they've got the big journey. When they get there, they've got to tell the clinician all the bad things. And actually, when you just log in and you just catch them in their kitchen for 20 minutes or half an hour, and you're in their life for a moment, and they haven't got that big build up, the patients seem a lot more independent with their rehab.
Gosh, what an interesting observation. Have you read anything on that?
It's just an observation, especially with our patients, which we manage with instability, atraumatic instability patients who are trying to get on with their lives, and there are other issues, maybe, and other drivers, psychological drivers, that actually it isn't helpful sometimes to come back into the hospital environment every time and really medicalize their problem. When they're living with that situation, and they just need a program of maintenance and just that little support, really. There's definitely, some of those patients definitely need to come in, but for that interim appointment, it's a really nice, or a little bit of reassurance. It's been a lovely medium to use the video conferencing and appointments.
I'm sure we're going to read more about that in the future. Well, let's talk about the patient for a minute, because that rehabilitation after surgery is not a pleasant experience for them. So first, let's just talk about who they are. I know when they get to doing shoulder range of motion exercise with a passive assistive pulley, or a wand or a cane, or things like that, we're finding that patient is between 55 and 85 years old. It's fun to talk about the athlete, but the whole bulk of them seem to kind of be in that advancing age group. Is that consistent with what you're seeing as well?
Yes, I mean, my practice is quite a large scope. So I'll have the 80-year-old arthroplasty patient. I'll have the calf tendinopathy and the frustrated weekend warrior of 50 trying to play tennis and golf. And then I'll have the early adolescence with instability. From a surgical point of view, lots of our patients, the instabilities get going very quickly and need very little input. And with the tendinopathies and the cuff repairs, they're the ones that tend to take quite a lot of time and reassurance on that very sort of up and down pathway and journey to recovery. So with the arthroplasties, they tend to do very well. And then depending on what brought them to the arthroplasty, whether they're trauma or whether it's an elective procedure, will very much depend on the outcome, and that prediction of outcome becomes more difficult if it's traumatic. Yes, no, there's a real mix, but I'd say the majority are in the sort of the 50s, 60s, having the tendinopathy surgery, the cuff tears.
And let's go on about your book a minute. There is obviously, just as I've watched you talk about it, have been some aha moments that you're saying, I see now that this or this maybe derived from research, but then you see it in actual practice that has changed how you've done things over the last 10 years. Any kind of general observations that you say, we used to do this, but now in hospital we're doing this, that you might want to share out of your book?
Yes, I think one of the big moments in my career in regards to success with treating my shoulder patients has been when we were visited by Professor Karen Ginn from Australia. And she's done a lot of work, her group's done a lot of work looking at the rotator cuff. And she collaborated with the Royal National Orthopaedic Hospital and Andrew Jaggi, who's a world-renowned physiotherapist in instability, looking at how to manage instability, atraumatic instability patients. And one of the areas that I found with atraumatic instability was using a lot of kinetic chain exercises and cuff work and bringing in the whole body and being quite holistic. And then there were a couple of cases that spring to mind where I just felt that we, with the athletes as well, that we just hit a ceiling. And it fitted nicely as well with the tendinopathy patients, where again, they would be doing really well, flying, but then they would just reach this ceiling. And and then just saying, well, is this it? And just maybe thinking, yes, maybe this is it. And then it was meeting Karen and reading her research, and a lot of the rotator cuff work in the book references her. And being very isolated with the rotator cuff, looking at it as a unit that's eccentric and concentrically controlling that humeral head through an arc of rotation, and then being quite systematic with the loading of this, changing the position from prone to sitting to supine, half support, full support, half support, no support, and being very slow with the arc and allowing that tendon to have exposure to load in its functional capacity as a humeral head stabilizer. And the patients I was talking about, where I just felt, even with the instabilities, that they would just get they would get pain, or that ceiling of control would be, really challenged, despite getting to a very high level of function or sport. And then I went back and I just isometrically tested that rotator cuff and found how weak it was, despite being able to generate quite a lot of power through the kinetic chain, but actually being very, very pedantic and isolating, and realizing that the capacity of that cuff just wasn't enough to be able to play tennis or, even run, because of that stabilizing role.
So then how did you back them down? Because particularly with the athlete, they've got their whole no pain, no gain thing. And it doesn't take long for the other muscles to sort of take over and help the rotator cuff. And then it can basically stop in its progression. How do you back them down out of that situation? What did you discover?
Yeah, well, I used a handheld electronic myometer, because they love a spreadsheet and they love scores. So then I for this particular athlete, this light bulb moment. It was about sort of 6 or 7 years ago. And she was, back to competitive, national level, but a lot of pain and a lot of teeth, grinding and pushing herself, and a lot of unhappiness. There's a lot of mascara and tears. However, we did some isometric measures, and she was actually quite shocked. And it was a really great buy-in to see how she was measuring isometrically compared to the other side through her range. And then actually isolate and just explaining that actually it's like a layer of an onion. And
right.
As you quite rightly put it, if the deeper layers fail, then the outer layers help, but they can't do the deep layers job.
Right.
So they're masking. So you're doing a very good job. And if it's just an everyday physical activity, you probably get away with this. But because you're a high level athlete, we need to be on it. So I would do those, and then I'd plot that trajectory. And the buy-in was great.
I see. So you were using digital outputs to kind of manage the patient's mental position on their own progression, because they could see it then, and then back down and say, oh, I've got to take care of this. I could see, for example, with a tennis player or someone who had to have, both acceleration and deceleration, that if they didn't have it, their return to play might not be nearly as effective as they'd hoped for.
And it's very interesting. So one of the biggest challenges as well is, I'm a middle-aged lady, and I'm trying to sell this to a 21-year-old rugby player, and they're looking at me going, what do I know?
Yeah.
And then you test their cuff with one finger and you win, and that's enough to get a young 20-year-old to listen to you. Yes.
Well, tell me again about this device you used, and I missed it in the difference in our accents. Tell me what you used to measure the rotator cuff strength there.
So I've got a digital handheld myometer. I think the make is an American make, Lafayette. But if you're using the constant score, the shoulder score,
right.
Just the spring balance, if you're inventive with your positioning, but it looks more fancy if you use something digital, especially with the athletes. Yes, no, that gives you, a maximum contraction. It gives you a peak. It gives you a range. So I use both in my national health and my private practice.
And it will get right down to the 4 tendons of the rotator cuff and help you.
Well, yeah, I mean, this is where the research comes in, looking at isolated tendon testing. I mean, I'm looking at just to get the patient to buy in. I'm looking at isometric into range of motion, and that's enough, really. I don't need to go into with the patient. I haven't needed to go into too much, but in regards to scientific robustness, I'm not sure if it holds up, really.
It'd be fun to put needles in everybody, but I don't think it's practical.
Yeah. Get your little myometer out. It's far easier, less scary.
What about the pain in the patient? Is there anything in your exercises that helps? When I read people that are in blogs or Facebook groups that are recovering, certainly a predominant comment is, I had no idea how painful this was going to be or how long it was going to take. Is there anything that you've employed to help minimize those two, amount of pain and length of recovery?
I think setting expectations in the beginning, and that's where I'm really fortunate to be in that clinic environment, working and feeding back to the surgeons, because the surgeons may see them at 3 weeks, 3 months, maybe again if there's some issues, but you could say we're lucky, or maybe not so lucky. We end up seeing the patients a lot more frequently, so we're on that journey, bumpy or not. And often the patient sometimes goes in and says, yeah, no, it's great, to the surgeon, but actually when they're in the physio room, they're going, oh my gosh, I haven't slept. Yes. What am I going to do? And you're on that journey, so you're hearing the week's events, and I can't do this, and I can do that. And I think having the mileage and experience, and therefore being able to reassure them, going, yes, no, it's really rubbish, and it won't be till 10 weeks that you think, I'm glad I had this done. So I often say to them at 3 weeks, when they're still doing very gentle, active, assisted work in the sling, especially with the cuff repairs, oh, I'm off my painkillers now, I feel great. And I'm like, right, well, the sling's coming off now. Be prepared, you're going to go back to those painkillers, because you're going to now be doing a lot more and a lot more exercise, and people around you are going to expect a lot of you. So beware, this is now bumpy. So from 3 weeks to 12 weeks, you're going to have a bumpy ride. And I think if they know, if you decatastrophize that, then you just bring that level of pain down a few notches.
Just because it takes the surprise piece out of it, and there may be
and the face says it as well, doesn't it? The face goes, I know, it's rubbish, it will get better, you're going to be okay. And they just go.
Well, these folks that are on these chat groups, they're anonymous and rather unfiltered. They tend to blame the surgeon, sometimes blame the physical therapist, but they kind of want to find somebody to hang the blame on during that period where they're waiting to get better.
Yeah, it's a difficult one, isn't it?
It is difficult. I find myself logging in from time to time and saying, hey, you have to own your own recovery. You have to get engaged in your own recovery. That's part of the reason we find it fun with shoulder pulleys, is if you hang a pulley on someone's door, and they look at it when they get up and when they go to bed, and they say, oh yeah, I've got to do this little exercise in a pain-free range. At least they're buying in, and they're saying, I've got to be part of this solution. So that's kind of our little help. But I think we all wish we could get engaged with these patients a little bit earlier and kind of set up their expectations a little bit better. And it's really, I think, encouraging to hear what you're doing with people preoperatively. I don't know if that's the NHS that's forcing it, but it seems good practice to see if people can find their way out of pain, because as we all know now, not every rotator cuff tear needs a repair. It just needs, based on where you are in life and what your work is, and how your body is responding to the pain. All plays a part. Everybody's a little bit different.
Definitely. And with the tendons as well, it's very interesting. I often use the analogy which I got from a colleague of mine, Val Jones, who's specializes in elbows over in Sheffield in the UK. And she uses a lovely analogy which really does help a struggling patient with tendon pain. And she uses the analogy of sunburn. So tendon, I think if I do her justice, so loading on a tendon is the same as sunburn and sun exposure on the skin. And, we can be underexposed, overexposed. And if we do overexpose, we get a little bit of sunburn. But we don't then just go into a cave and stay there all summer. We look after it, we settle a little bit, but then we get back out there. But we're a bit more careful. And yes, we pace that approach and that exposure. And then we get the resilience of the tendon up like we get the resilience of our skin. So by the time we get to the end of the summer, we can take a little bit more sunshine with some sensible steps.
Yes.
I think it's a lovely analogy. Patients love it.
Yeah, having floated the river in an inner tube and burning the heck out of myself as a boy, I now am very watchful, but we do get through it. That's a good place to go. Julia, to conclude, tell me what you and your colleagues are hoping will be the result of your published work. What were you hoping would be the outcome?
So really it's there to guide my colleagues. I do a lot of work where I'm working with other therapists who aren't as experienced. And it was the other authors and I, our aim really of this was to share with it our experience, where there wasn't the evidence, our consensus on exercises and really just increase people's repertoire with the science behind it, so that there was a guide. So the book is divided into early, intermediate, and late phase exercises. It has the evidence to back that up, but also it gives you the value of the exercise. So if there's an exercise that just works on range in the early stage, there's also an exercise maybe that has more value. So there might be an element of proprioception, an element of range, and a bit of kinetic chain. So you can tick off a few more boxes. So when you're prescribing exercise and you don't want to overload, and you want to address these key fundamental rehabilitation issues, it's being wise with your choice so that you don't overload that patient. And then, you know, when things get stale as a clinician and you want some more ideas, then it's like picking our brains.
Yeah. Well, congratulations on your book. And I'm happy to introduce it to people here through our blog here, our video blog, and hopefully you'll get some more people following what it is that you do. Thank you so much for joining us today. It's 11:30 in the morning here. What time is it there?
It is, good question, 7:30 in the evening.
Bless your heart for hanging in with us. So
Pleasure.
have our morning coffee and have a chat with you.
I have one question for you, Julia.
Okay.
Early on, you said that you were into pediatrics now, and just wondering, are you seeing any increase in kids that are playing games, gaming systems a lot? Any injuries there?
Not so much with the gamings. I'd say what will be interesting and is unfolding is the lockdown effects of underuse and poor fitness, and now getting back out there on the pitch. So the boom bust. So that might have a link with gaming and sedentary lifestyles that's being compounded by the pandemic. And the other thing, sadly, is the psychological aspects of the pandemic on adolescents.
Right. Okay.
And we're starting to see that trickle through. And there were a few, you know, difficult cases. But now the sun is coming out and we're seeing some hope on the horizon. And some of these individuals have turned a corner, which is lovely to see.
Good.
Okay, well, thank you for joining us, and perhaps we'll have a chance to chat again.
Lovely, it's an absolute pleasure. Thank you for having me.